Thank you, Marguerite Mongeon, for that wonderful introduction. And I also thank you to the French American Aid for Children for having this wonderful event, and I'm excited to be here. I thought I'd sort of set the stage by comparing America and France because we have both, represented here. To set the stage for this, we go about 2 decades back to when liberal prescribing of opiate painkillers began in this country. The opiate abuse is something that is much older than that, obviously, but there was a priming that I'm going to get into in my lecture. But just as a snapshot here, between 2012 and 2014, Americans were prescribed more than 5.5 times the amount of opiate painkillers that the French were. And there's no difference between the amount of pain that each country was experiencing. And in fact, it isn't surprising to find out as well that the life expectancy in France is better possibly because of this. And we'll get into it as we go. So just to also set the stage, the Centers for Disease Control, they have reports about how many people have overdosed each year. It went to 2016 numbers were 64,000. That was a 21% increase over the year before. The 2017 numbers are in 70,000, only about a 10% increase. Even though that seems like a modest change, experts in the field, we're hoping that is the beginning of the curbing of this really, really devastating epidemic that we're experiencing. And it's really a sobering thought to think that all the American servicemen that were involved in the Vietnam War during 20 years, only 58,000 servicemen were killed. That number is eclipsed every year right now as we're speaking in terms of opiate overdoses. So in 2016 here in the city, we're going to look at the numbers here in the city. We had a devastating and a very, very scary increase between 2015 and 16. 51% increase of overdose deaths. And then the 2017 numbers have been curbed to a 2% increase. So again, more reason for hope, and hopefully some of the things and the interventions that I'm going to be describing during the lecture might account for some of the tempering of the deaths that are occurring. 1 in 40 New Yorkers, almost 4. It's 4.95 something or other. New Yorkers are dying every day from fatal overdose. And I just wanted to show very, very quickly as well other reasons for premature death that are famous, like car accidents and murders. Those are the blue and yellow lines. And what we're seeing on the purple line is overdose deaths. So we can see the discrepancy in how premature death is really being taken over by opiate overdoses. So this slide briefly shows you the most very, very even split of demographics throughout geographics, socioeconomic status, ethnicity, and age. There's a very, very even split over where this is being affected and who is being affected. The only outlier is male to female. You can see that males account for almost 80% of fatal overdoses. But otherwise, it's a very equal opportunity kind of situation that's happening. And the map of sort of the density of where the opiate overdoses are happening. The hotspots, generally speaking, 2015 and 16, the map hasn't been made for 17 yet, but the hotspots are, in the Bronx, Upper New York, and in Staten Island, as you can see. it doesn't have to be an absolutely amazing interruption. At any time, if somebody needs to see something, just go ahead and speak up. I'm just going to, make my. It's okay if you want to just make a comment. So I just want to give you some background on what we're talking about in terms of opiates. The opium poppy was discovered 5,000 years ago to have euphorogenic and pain relieving qualities. And amazingly, really, many of the medicines and painkillers and drugs of abuse are very, very closely related to the derivatives of the opium poppy. Here are some of the names, the scientific names of opiates. They're all painkillers and used primarily for that. And they're all stemming from the family tree that started with the opium poppy. And here's the family resemblance. As you can see, the drugs of abuse, moving on to the painkillers, you don't need, as I say, you don't need a PhD in chemistry to see the similarities there. So just as an educational point. Now there's a new, and this is a very important point of my lecture, there's a new synthetic version of opiates that was originally made for pain for cancer patients. One is called, it's the fentanyl derivatives, and this is the fentanyl molecule. But this has been discovered by black market to be very much more cheap to produce than heroin and is much more powerful. So now black markets all over Asia are producing this thing, and this has just happened, and this is key to my lecture as well. In the last about 3 or 4 years, the market has been flooded with this. It's scary because the synthetic opioid, the fentanyl is 30 to 50 times more powerful than heroin. And then there is another derivative called carfentanil that is percolating into the market as well. Basically, that's a chemical weapon. I mean, if that's airborne in any way, it knocks people completely out. Up to 5,000 times as powerful as heroin. So when heroin is used, just for your knowledge, and I'm not going to spend a lot of time on this, but when it's used, the addicts will be measuring a very, very small fraction of the drug to use and to manage themselves. So you can imagine if you're throwing in some of these, what they call cutting with heroin with some of these other derivatives, how dangerous that can be. It's part of the reason that we're seeing this explosion in overdoses, because the drugs of abuse are even more of a roulette, Russian roulette than prior, if that makes sense. I was just going to mention as well, it's being packed into pills and was even discovered in upstate New York being smuggled disguised as sweet tarts, which is horrifying. Okay. And here's what I'm talking about. In the last 3 years, in New York, initially in 2015, before 2015, about 5% of overdoses were fentanyl and fentanyl related. That number up through, we have 2017 numbers, is now 57% of overdoses are fentanyl related. So this is, sort of a perfect storm of situations where we've primed the opioid epidemic with liberal prescriptions, which I'm going to get into, and fentanyl, as people move from opiate prescriptions to become less available, they move to drugs of abuse, and the drugs of abuse are laced with fentanyl. So this is part of the reason that things have escalated the way that they have. Here, just as a point of interest, oh, I have my laser. I'm excited about my laser. Okay. So this is a lethal dose of carfentanil right there on the penny. This is a lethal dose of fentanyl, and this is a lethal dose of heroin. So you were already measuring very, very small amounts, and now it's beyond being able to be measured. Okay, so this is just an overview. I know this is a very busy slide, but I just wanted to give you the overview of the two main city initiatives that are being that were launched recently to address both the opioid crisis and also mental health. Healing NYC is the response to the opiate crisis, and the goals and strategies that you see below are the ways in which we are beginning to intervene. The city is intervening with the opioid crisis. The Thrive NYC initiative is a similar initiative for mental health, but it's important because part of what we're doing for especially family and for children is piggybacked on the Thrive NYC program. So I'm going to be mentioning that as well, and I don't want any confusion as I do, or try to minimize confusion as I do it. So I'll be talking more, and I'll be returning to these strategies just to, sort of itemize where I'm going with the lecture. Okay, so let's move to the solutions. That's enough on the problem so far. I'm going to get back to the prescription issue in a little bit when we talk about prescribing habits changing in doctors, okay? But for now, I'd like to just talk about strategy one. Goal one has one strategy, and that is just a direct intervention to overdoses that are occurring. Naloxone is an amazing reversal agent. It's very, very safe. I like to tell the stories when I do trainings for people that are nervous about potentially, using this because they don't want to feel like they're, some kind of doctor or something. If you have somebody on the street, let's just say out by Grand Central Station, the person's completely out. They look like they're in a serious distress. A Good Samaritan calls 911. The paramedics arrive, and they don't know the person's name, age, allergies, any medications, medical history. They know nothing about the person. One of the first things they do if it looks like they're not breathing is give naloxone, because if in fact it's an opiate overdose, person is going to be revived. It's amazing, and I've seen it happen many times. If not, no harm done, and then they move on to the next thing. But it's that safe, and that's why it's part of the protocol right away if it looks like somebody is, again, not breathing and turning blue. And that's what the training is about. The training is really for, I should mention that it comes in a very user-friendly nasal spray now. It used to be an injection. They've moved on so that it's very, a good citizen can use it very, very easily. And you can see a picture of a dose being lost to the air, but it's supposed to be in somebody's nose. Spray it. That's it. So when we train folks to use naloxone, basically, to keep things simple, there's details involved with it, but to keep things simple, when I train, I like to go back to the 1, 2, 3s. You've got to recognize that a person is overdosing by not breathing. Basically, that's turning blue. And you have a small intervention to try to see whether they're awake, and that's called the sternal rub. That's what we do. That's in medicine. That's a way of slapping people in the face or pouring water on them. We're not allowed to do that, so we use the sternal rub. And then call 911 and give naloxone. If you know nothing else and you have this kit, that's all you need to know to safely use it. So basically, when I do the training, I return to the basics and remind folks of that. By the way, we have some examples of the kits here, and then we're going to have in the back afterwards just ask about naloxone. We can give you more information or even a training. So that's exciting. And also just an easy way to find naloxone is now available without a prescription. Many insurances will cover it. This website, if you click on it, will give you a PDF list of hundreds and hundreds of pharmacies throughout the city to be able to get it, without a prescription and insurances cover. And I often say, this is more possible resources for finding an naloxone kit. I often say that you don't have to have opiates in your past to save somebody from an opiate overdose. So. Okay, so again, here's goal number 2, and there are 5 strategies available or that are being used by the city to make a difference in this area. Strategy 1, we're investing in, again, I'm going to return to this, but I'm giving you an overview, and I'm going to spend some time talking about youth intervention. And all of these campaigns that are happening in the city right now to curb the opioid epidemic. Strategy 2, okay, so here's where I'm going to pause and give us some time to sort of really digest some of the things that are happening. in the city on the behalf of family and children. So the first thing I want to say on the outset is that my experience, my direct treatment experiences with adults. However, I will say that I get a view into these patients' childhoods, because many times the issues of neglect, the issues of trauma that come up, shock to the emotional system, will create personality styles and create, post-traumatic stress that we know, but from evidence, predisposes people to substance abuse. So the most important thing, all of these other interventions that I have talked about and treatment and everything else that I've talked about, there is nothing more important than paying attention to the family structure and to the experience of children as they're brought up to thwart and to avoid substance abuse later in life. And I see this all the time. Folks that have histories of trauma, abuse, sexual abuse, other types of experiencing violence, experiencing neglect. The stories are constant in my field. So I can speak firsthand that this type of prevention and the work that an organization like this does is as important as any direct treatment for addiction. So let me kind of outline a few of the other things there. I know this is again a busy slide, and we're going to spend some time at the end of the lecture and during questioning to be able to talk more about some of the interventions that are happening. Schools are being infused by NYC Thrive, which is the mental health response, with more mental health support. Some community schools now have mental health professionals built into the school. Others will have consultants. They are beginning programs that there's a lot of evidence to show that an intervention called social emotional learning for very, very young children to begin to be able to regulate and to have more tempered responses to their affect, to be able to manage their affect. This kind of training comes from all kinds of ways that caregivers can intervene. For them to learn how to take timeouts when their affect escalates and they're having trouble with their emotions. Also, to have empathy with other children is a higher functioning emotional state. To be able for children to begin to learn that at an earlier age is a very healthy thing. All of these interventions that I'm talking about, again, avoid the end result of what I've described in some of the adults that struggle with substance abuse later in life. So, 130 community schools will have mental health services on site. 56 of them have mental health services on site, and 130 are getting an assessment with substance abuse counseling. So again, there are also programs that are making early childhood and mental health training and technical assistance available to families in need, specialized clinics in all 5 boroughs that provide family-centered mental health care. There are a number of ways. Also, there are now trainings and mental health clinicians that are being dispatched to foster homes as well. Family shelters are a very, very useful target for some of these interventionalists to give more structure and to provide support to the family structure, which is so important for the development of children to avoid some of these substance abuse and conduct issues that come later. Okay. We have a NYC Thrive social worker in our department now. It's not specifically directed at children, but again, the mental health initiative is one that's very, very wide-reaching, and we are also some of the benefactors of that here at Woodhull Hospital, where I work. So again, the only other thing that I will mention about my treatment experience, and I'm going to talk more about that, is our work with the Administration for Children's Services. We advocate for clients to begin to build back their lives and to build back custody of their children, and to work with Children's Services in that way. And give them a trajectory that gives a more stable life, which, in the end, will help children thrive and live healthier lives. Briefly, just going to, everyone has seen some of these campaigns as an effort to destigmatize addiction, to give people more information about what treatments are available, to destigmatize those treatments, which for a long time have been stigmatized. I'm going to get that in briefly as well. I don't know where I mentioned there, but naloxone and training for librarians is very important, because apparently there's a lot of saving being done behind the stacks in librarians. But again, there are a lot of things that are available to, and you've seen the subway ads, and there's an aggressive campaign to get the word out and to get the stigma for treatment under control. Okay. So I was going to mention also the New York City HEAL initiative is sending for the hardest hit. Those were the darkest parts of the density map that I showed you at the beginning: Staten Island, Bronx, and Upper Manhattan. People are being dispatched to the street to try to talk to people about treatment, to try to talk to community centers, those types of places, about naloxone trainings, etc. Okay, spending a little time on this, because I know I promised you, how did it all evolve in the last, how did the opiate crisis evolve? How does Dr. Warren think that potentially there was a priming done back in the early 90s into the 2000s? In my training, as a medical student, I will always remember how much emphasis was being put. We didn't know at that point where it was coming from, but generally speaking, that, treating pain was the humane thing to do, that in fact, treating pain for somebody who has chronic pain is, with opioids, is not an addictive process. So there was a lot of misleading information, I think, that started doctors on a path of very, very liberal prescribing, ongoing chronic opiate prescribing. Reimbursement was even involved back then. This was the idea of the fifth vital sign. You take blood pressure, heart rate, O2 sat, and also pain. And if the pain is too high, and the patient reported that the pain was too high, then you don't get as good reimbursement. So there was reimbursement. Doctors were encouraged through reimbursement to extinguish pain, and we now are realizing that extinguishing pain is problematic for a number of different reasons. One is addiction. The other is you don't really heal that well, because we evolved pain for a reason. So an important thing to realize is that we evolved pain so that we know to rest something, so that we know that we can't move in a certain direction. If we have opiates on boards that are extinguishing those signals to our brains, then we remain hurt or we injure ourselves further. So it wasn't a very good strategy. As people developed tolerance to opiates, their pain was even worse, because their pain system, as they develop tolerance, is reaching through the opiates that are on board to try. So when the opiates aren't there, their pain is worse. There are a lot of reasons that things went south. And here is what happened in terms between 1991 and 2013. We went from in the order of 75 million opiate prescriptions to, at the peak in 2011 and 12, about 217,000. I mean, I'm sorry, did I say 1,000? Million prescriptions. I didn't say 1,000. Okay, so here's the end of the escalation of prescriptions, and I'm going to talk briefly about some of the interventions that curbed doctors' prescriptions down through 2014 and 15 and 16, but look at the overdose rate. It didn't follow the prescriptions, right? Number of reasons for that. The opiates had already primed addiction, and remember what I said? Fentanyl came on the scene right about now, right about in this area as well. So I think our numbers are sort of a perfect storm of a situation where people, move from, and, the heroin users I was going to mention, heroin users, 80% of them started with painkillers. That's basically the statistic. So they move to drugs of abuse, and then these drugs of abuse are devastatingly dangerous because the proportion of fentanyl that's on the street now. So I just thought I'd mention that as part of the paradigm and part of the perfect storm there. So we are curbing and have successfully are beginning to change doctors' habits in terms of prescribing. There are a number of things in play. One is a prescription monitoring system that every time you prescribe a narcotic medication, you have to check the state registry to make sure nobody else is prescribing narcotics. That's created a lot of traction in terms of doctors' prescribing habits, and also has curbed what we call doctor shopping, where more than one doctor is involved with a person collecting prescriptions. There are also new guidelines that have been put out based, locally within the judicious prescribing guidelines within our hospital system, but also nationally from the CDC. And from the Opioid Crisis Response Act of 2018 as well. We have new modalities, and basically opiates are really supposed to be, and it should be appropriately prescribed. There's a place for them. It should be for acute pain or end-of-life chronic pain. So acute pain, a couple of 3 days worth of an opiate prescription of a short-acting agent, and then move to a non-steroidal anti-inflammatory of some sort, like Motrin, but not spend a lot of time on opiates. It's known that within 5, 7, 10 days, addiction can occur if you take opiates. It's possible. So yes, and there's on the recertification that we had for our DEA license, we were trained. All doctors were trained in judicious opiate prescribing, and you could see from this that it's working in terms of the doctors returning to better prescribing habits with opiates and educating their patients in an appropriate way about the use of opiates. Hopefully that will help. Just going to very briefly talk about some of the city's interventions in terms of treatment. And I'm a direct recipient, or we are in our department at Woodhull, a direct recipient of some of the teams that are now just being dispatched. We're getting extra personnel to engage patients that are in the emergency room, as well as on inpatient units that don't get a lot of attention for their substance abuse treatment. The doctors are really concentrating on the acute issue, whether it's an infection or something. They don't have a lot of time to say, hey, do you want to be in treatment? Do you want to start a medication? So there are new teams that we are hiring and dispatching throughout the hospital system to help with that, to get more people into treatment. There's only, at any one time, there are many, many opiate addiction diagnoses out there, and only a small subset of folks are in treatment, 15% at the most. So. Almost done. So again, we need to connect New Yorkers to a treatment. The treatment of choice is methadone and buprenorphine maintenance. So yes, opiates, to treat opiates in a structured environment. This has been shown over and over to save lives, to reduce the disease burden, to reduce mortality. I know that there may be questions about that. I have limited time, but there may be questions about that we can happily address, Dr. Taki and I. But it's just shown that it prolongs life very, very simply, and improves quality of life. So medication-assisted treatment is the treatment of choice for opiate addiction. So also as a psychiatrist, I will help also in early recovery with other types of medications for anxiety and depression, for post-traumatic stress, as I mentioned. Here's a methadone clinic. I won't talk a lot about that, about how to start it and all of that stuff, but it's, provides a lot of structure. A person will come in, they'll collect their dose, they have other services there, there's monitoring that is involved, so the structure is just as important as the medication, and the structure comes with the medication, so that's what is a terrific, it's a great paradigm for helping people. Also another choice is buprenorphine naloxone. That is a medication that can be prescribed out of the doctor's office as opposed to designated methadone clinics. Again, is helpful to have treatment with it, and I like to do that. I prescribe this medication, but I also like to have structure as well. Again, the only thing I will say about this is I wanted to mention France as, the DEA here really monitors doctors very, very carefully. They have to get a special license on their special trainings and a special license on their DEA to be able to prescribe this. And it's a very sort of draconian type of feeling. And I think a lot of doctors shy away from treating that because of the extra pressure and the extra training that's necessary. From my point of view, it's just another medication that has not just a little quirk to it without going into a lot of details and having to start it. And in other countries, it's just another medication. Doctors in France are prescribing this, without their training, without extra monitoring and all of this stuff. So I think that that's an important thing. And they have been able to really make headway in terms of treatment access. So just as an aside. Okay, and naltrexone is another choice. This is the third FDA-approved medication. It's a blocker of opiates. It's a little more difficult to start with folks because they need to be washed out of, obviously, the opiates they've been using, and that can be an uncomfortable period, but it has shown efficacy as well. And here are some of the studies that show over, many years to show outcomes with medication-assisted treatment. This one's for methadone, but clearly the outcomes are so much better. Here's this little model is what happens when you treat, so high blood pressure is a chronic condition just like addiction is. There's no cure for it. You give a medication for it. Before you do give a medication, there's a lot of disease burden. As you do give a medication, it's reduced tremendously. As you stop or you discontinue, it's increased again, but maybe not as much. The same is true for medication-assisted treatment in opioid dependence. All right, and again, more evidence for the buprenorphine and naloxone, which is the newer kind of methadone, basically, and more outcomes here. And also, I just wanted to mention post-acute withdrawal. That is a syndrome. So when somebody is withdrawing from alcohol or from opiates, which is the topic today, there's a physical response that's very, very acute where people need to be stabilized for. If they get through that period, there's still a physiological activation that occurs for many months afterwards that can be treated effectively with non-narcotic medications or can be helped with non-narcotic medication. But there's still a transitional period of about 4 to 6 weeks where things are uncomfortable. And I've already talked about the teams that we're dispatching amongst the city hospitals, so I'm just going to kind of move through that. This is a lot of details about the teams. And also, one of the last strategies is in the criminal justice system. I won't spend a lot of time on that except to say treatment versus incarceration is still an effective way of working with folks to get them into treatment. So the Eric Gonzalez, the Brooklyn DA, had a new initiative in terms of this. And, basically a final pie chart to show everything that's involved with getting better from addiction. And there can be a lot that we can do on many different levels to try to help with that. And then one last random but dangerous fact. Okay, so again, I'm going to, at this point, that's my lecture, and I'm going to hand over the floor to the esteemed Dr. Taki right here.
Hi, thank you. So hello, everyone. Thanks for coming tonight. I really am excited to share with you some of the cases that I've seen throughout my 10-year history working with people with a severe opioid use disorder, and share with you some of the transformative power that methadone maintenance in particular can have for individuals that are struggling with this illness. I'm just going to move to my name. There we go. As Marguerite mentioned, I am a specialist in addiction medicine, and I've worked in multiple settings. I've worked in private practice, I've worked in detox rehab, I've worked in primary care, and throughout that whole time, I've always maintained a practice in methadone maintenance treatment because it's the place that I see the most benefit for patients and the most transformation in terms of people getting a quality of life back. And so I'm just really happy to be here to have the chance to tell you about it. The first person I'd like to tell you about is a woman who, she had the kind of life that I think everyone here would like to see for a child. She had every single economic opportunity you can imagine. She grew up on Long Island to a Caucasian family of very educated and professional parents. She did not have any abuse, trauma, or neglect in the family. She really had everything you'd want a kid to have growing up. Unfortunately, she was injured in a snowboarding accident and had multiple injuries requiring 2 years of reconstructive surgery. And during the course of that, those surgeries and that exposure to opioids, she became addicted or developed a substance use disorder with opioids. I actually met her about 5 years into treatment. So she had, by the time I met her, gone through all the different stages of treatment that you mentioned, Dr. Warren. She had done intensive residential treatment. She had tried Suboxone or buprenorphine naloxone maintenance. She tried it all, and she eventually came into methadone maintenance, and that is what gave her a quality of life back. That's what allowed her to finish graduate school. It's what allowed her to not use drugs, not crave drugs. If she were to have a slip with drugs, she would not have felt the euphoric effects of those drugs. And she was able to marry and then plan a child. She successfully had her baby. I saw her through that pregnancy. She did quite well. The NICU course was uncomplicated, and she went on to have a very successful and rich professional life and a very successful and rich family life. Part of the problem with methadone is that people like her don't speak up. There's this whole invisible population of people that are treated with methadone maintenance that really aren't going to raise their hand in front of a big group of people and say that this saved my life, this stopped my drug use, this allowed me to pursue my dreams. And so what happens with methadone maintenance a lot of times is it gets judged by the sickest patients. So you see people with multiple addictions that may be identified as people in methadone maintenance, but the people that are really, making that perfect recovery that everyone wants to see, they're just invisible to the rest of the world. But they're not to me and Caitlin and Corey and the rest of our staff. So you may also wonder, so if this is such a great medication, why is it more women don't do well or more parents don't do well in treatment? And I want to say, first of all, a lot do. There are a lot of really successful people in treatment that are able to parent their children and maintain the family structure that you'd like them to see. And then for the people that can't do quite as well, I just want to suggest the possibility that perhaps we're relying a little too much on the power of the medication. So methadone is a medication like anything else, and it can help a lot. But just like if you had cancer, you would need potentially physical therapy. You might need someone to watch your child while you're going through your chemo regimen. You might need somebody to pick up your kids. I mean, there's a million things that happen when people have a serious illness. And a lot of patients are not as privileged as this woman was and have a lot more stress and challenges in their life. And so if, for example, there was a group of women that could mentor this woman, women that are pregnant through their pregnancies, if they have to be maintained in methadone treatment, that would improve outcomes. I worked in a location that had advocates for both patients and for parents. And that was a huge deal because as a parent myself, I know that if protective services was involved in any way, I would be highly anxious around those visits. And we know that people that use drugs often use drugs to cope with anxiety. And so what we had the luxury of having in that setting was a parent and a patient advocate. And so people that were struggling to recover, they had someone in their corner. They had someone to go to those visits with them to explain, what their rights are and what things they can and can't do at certain stages in their recovery and process with protective services for children. And the last thing is just really structural, and I speak as a mother around this. There are some programs that have on-site childcare, but they're not the norm. And so what you ask of a person who's struggling with recovery when they don't have a family to watch their children, when they may not have the money to pay for childcare, is to then bring their child sometimes 6 days a week to a program and leave them in the care of maybe a secretary who's wonderful, lovely, but distracted and doing a lot of things, and go get their dose of medication. And that causes a lot of anxiety, and it makes it really hard to find the time to receive the therapy that they need. I know that if I were to sit next to my 2-year-old and try to have a therapy session for 45 minutes, I would not get very much accomplished, nor would I feel very comfortable discussing a lot of these really deep and important issues. And so I just want to mention that I think that we can improve outcomes if we improve the way that the methadone treatment is delivered in this country. The next case I'd like to tell you about is not so much a case of treating the parent to treat the child in a way, because we all know children really want healthy parents. That's the best outcome we can have. I think that's clear when you treat a mother or a parent that the outcomes are better for the kids. But this case really demonstrates how treatment helps a whole family unit. So I took care of a gentleman who was African-American gentleman from East Harlem. He had been in methadone maintenance treatment for about 20 years, and like the other woman, he was stable for a very long period of time. And so what methadone was doing for him was suppressing his withdrawal symptoms. It was treating his brain. It was reducing the cravings, and we know that cravings and triggers are the most dangerous things for people with addictions. It's not withdrawal. People can get through withdrawal. What the benefit of medication-assisted treatment is really around treating the brain and reducing the risk of relapse from cravings and triggers. And so he had worked for 20 years and at some point developed some cognitive issues around his age, unrelated to drug use. And he needed to start coming to our clinic more frequently because we know that if you can't remember if you took your dose of medication, that you're at risk for overdose. So he would come 5 days a week to our clinic and was able to maintain his life in the community. And at some point, excuse me, he needed surgery. Sorry, can I get a glass of water? Sorry. Thank you. Speaking of children, I have a sick kid at home. So he needed surgery at some point, and he couldn't come to our clinic 5 days a week because he couldn't ambulate. So his daughter had to get involved and help manage both all of his medications, his recovery. And what I realized in meeting with this woman was that her father being in treatment meant that he could provide for his daughter, be a grandparent to his grandchildren. When he started to develop cognitive delay or cognitive difficulties, he could go more frequently, and he could maintain his place in the community. And then, and that really freed up his daughter to succeed in life. And she was able to pursue her professional goals, to pursue her what she wanted out of life. And so it wasn't even just about a parent and a child in treatment. Really, like the effect of having this gentleman in treatment really stabilized the entire family unit. And I've seen that with grandmothers that take care of multiple children as well, that are the primary caregiver for their daughters. And they can be stable in treatment and provide 4 or 5 people with childcare that allows them to work and pursue other goals. So you all came here. I hope I've given a little bit of justice to the power of methadone maintenance. And I just want to take a few minutes to talk about some things that we all can do to fight the opioid epidemic. Number one is really safeguard medication. Tylenol or acetaminophen, aspirin, all medication has the potential to do harm. And we know that adolescents in this recent wave of opioid use really got access to pills that were not prescribed for them. And so that means they were rummaging through someone's medicine cabinet, someone's purse, someone brought somebody's meds to a party, and I hear a lot that I didn't know that Vicodin would hurt me. Like I didn't realize it was just part of the mix of the party. And so safeguarding your medication is a conversation we have every day in our clinic with people, and it's something that you can do, it's very tangible in your own homes, is to just make sure the only person that has access to medication is the person it's intended for. The next one, I think you covered really well, Dr. Warren, is just reasonable prescriptions of opioids. And I think we've done a really good job in this country reducing the number of prescriptions. What we didn't do a great job is treating people who got addicted throughout the course of this. And so part of that rise at the end where the prescriptions went down was a lot of people just getting cut off abruptly from their opioids. They weren't tapered, they weren't referred to a treatment provider. It was just like, I'm sorry, you have another illness, it's called addiction, and I can't treat that, so goodbye. And it didn't help. It really didn't help the epidemic much. The next thing is naloxone, and I want to offer Greenwich House as a resource to anyone who would like to come in and get trained in how to use naloxone for overdose prevention. I think the idea is that this should just be pervasive in the world. In other countries, it's over the counter. We're lucky in the city because the city provides it free of charge to anyone who's interested. Your insurance does not get run. Nothing identifying gets associated with the kit. But the more kits there are, the more people that will be given a second chance. And I think they should be kept with defibrillators, honestly. Like you go for an emergency, you need a defibrillator, you also need an Narcan kit. And most buildings have a defibrillator in the city. In terms of children, I strongly believe that you treat a parent and you get a better outcome for a child, and that's really the focus of what I'm talking about tonight. But I think beyond that, we know that sometimes parents can't parent, and there's foster care, and there's aunts and uncles and grandparents, and sometimes adoptive parents. And I think the best thing we can do is really, in a developmentally appropriate way, is to teach kids about the medical illness of addiction, that it's a problem with the brain, that it's not some social deviancy or some internal flaw in the people that suffer from it. And I had the chance of speaking with our school psychologist, who happened to have done her thesis on opioid use disorder in children. And, and she gave some really good basically like guidelines about what age you can talk about which things, and I think we can really utilize our school psychologists and destigmatize it by talking about it universally with children, and really support them with a lot of love and support, because it is a medical illness and it needs to be treated with compassion and empathy. I think that's most of what I wanted to say. I just want to thank a few people. Dr. Mary Jean Creek is a giant in the field, and I know she's affiliated with FAAFC. She is the reason I'm standing here tonight, and she has some recommendations. I think you have them available, right? Okay. We didn't get them. Okay. Anyway, they're very reasonable and wonderful recommendations. But I just want to say thank you to her for giving me this opportunity to speak with you. The next person I want to thank is Dr. Warren, and then FAAFC. I think having these discussions, especially in institutes of higher learning and prestige, is really important because it destigmatizes addiction for everyone, and it elevates everything for everyone. And then the last person was sort of a surprise guest, but Val Bonilla, I'd like to point out. Can you stand up for a second? So Val is here. He taught me almost everything I know about methadone maintenance. He worked for 40 years at Beth Israel as the chief physician assistant and has trained thousands of people on methadone maintenance, because one thing I didn't touch on is no one gets training in medical school on methadone. And we get very little training on substance use disorders, and almost all of my training happened the second I took a job in the field. And so Val has been just a huge advocate and educator in the field. So I want to just say thank you for being here tonight. And with that,